Dr. Singh.
Okay, case number 8, if you can show the case number 8.
We are seeing case number 8.
Yeah.
Go right ahead. 72-year-old male with dyspnea on walking one
Yes.
block.
Dyspnea on walking, and if you see, what happened is the dyspnea was walking was related to significant coronary risk factors, but normal EF, okay, severe aortic stenosis. So he had a mean gradient of 41, okay, and then what happened is came to see me as a part of tower workup, had coronary angiography, so which had shown 2 vessel disease, calcified significant disease of the LAD as well as the circumflex, OM1, OM2 bifurcation. So syntax score, if you see borderline, so this is where I am, the discussion always comes when they see us somebody with a young age means, not young, borderline, less than 65 should go for definitely surgery, 65 to 80, 85, somewhere where we zone where you have heart team discussion, especially if it's 72, significant CAD, that should we consider for AVR plus bypass. So the heart team discussion happened between physician and the patient opted for PCI plus tower. So since the lesions were tight, when we say tight, about 90-95% and a young guy, we decided let's do PCI first and then tower. And I think during the top 10, Dr. Sharma did mention, because in Europe, I know most of the time PCIs are done at the time of the tower, but we try to do it before and then do the tower later. Borderline cases, sometimes we do it afterwards. So now the question comes, LAD was done, RCA was non-obstructive. So you see the LAD that was, you have cranial picture?
Yes.
Nicely done.
Very good.
Calcified. Yeah, so now we have this lesion.
Yeah, well, it was definitely a dominant
bifurcation,
branch and a side branch.
Yeah. So in the CT scan, it said calcified, but here in angiography, looks borderline in the sense that we don't think we see any calcium. What is happening?
Setting up the OCT.
Okay. Can you do hands?
Yeah.
Okay, so we have OCT ready just to understand, plaque morphology.
Yeah.
It's going to be very, very thick superficial calcium with AS and stuff like that. Chances are that's
Bring
very
the
bad
OCT
calcium.
closer to us. Where is the Kiski?
Yeah, I'm
Okay.
here.
So you're going to tell me when to inject?
Yeah, I tell.
So Dr. Singh thinks it's superficial calcium. Let's see what the OCT says.
Close.
Now, a couple of points before we do OCT. 2, if the lesion is tight, you have to, when you are...
Yeah, can you show that OCT on the...
No, we're going to see that there is a...
Yeah.
You see a blood flow clearing.
Yep. Can you check the path?
Ready?
Yeah.
Good. Go. Do you see clearing?
Yeah, good.
Okay.
Okay, 1 second. Enabling, 1 second. Calibrating. Yeah, please, cine, inject. Yeah, beautiful image.
Good.
You can take it out.
All
So
right.
it has to be done right.
Dr. Moreno, get ready to
Yep.
comment on the OCT.
Okay.
Okay, flush.
The quality is high.
Whatever it is the OCT says, Dr. Singh is right.
I did angiocalcillation.
I don't understand this superficial and deep calcium. Yes.
Why is not taking you're saying re-enter?
Well, looks like
Okay.
the software, the acquisition was good, but some kind of reconstruction is
Okay.
high quality, that's for sure.
This is our lesion.
Yeah.
So this is a
it
proximal
has
sac.
both.
It's definitely, this is
Very
like
deep.
360, not that thick, but it's calcium.
Yeah.
And our tightest lesion is, this is definitely something protruding. And the surface is kind of smooth. But anyway, it's a calcified nodule. Calcified nodule.
Nodule?
Yep.
And go to, where is that calcium you showed us?
Yeah, proximal to the nodule. You see the like 360 calcium here.
Yeah, 360
Not
calcium
thick,
there, yeah.
Yeah.
Yeah, but this is calcium. So substantial calcium proximal to the and distal to the lesion, and something protruding inside. Sometimes it mimics the red thrombus, but based on the OCT criteria, it's calcium nodule.
Okay.
No,
what's-
yes, we understand, but based on the OCT criteria, does it meet your
Well, do we need to do the ROTA is the
the
question.
rule of five? Can you
The
mention,
ML
discuss what is the rule of five? What are the rules that we use?
Sure.
That if your calcium is 180 degree, which is 0.5 of the circle, right? 0.5. So that is one. Then the thickness of the calcium has to be 0.5.
Yep.
And then the length 5 millimeters,
Yep.
right?
Yep.
Then you give the points. So
So first, like this orange color, this AI integrated ultrasound tool, it detected almost 360 calcium. So it's anyway more than like 180 degree calcium. So MAC is more than 180. And the thickness I measured, this is more than 0.5. And the longitudinal length is also
All 3
like,
points.
This is the start of the probak.
3 out of
it's more
3
than 5
made.
millimeter.
okay, so what we are saying then you have to
3
do
out of
rota.
3.
This
Four
is
out of 4.
top of that, you have a calcified nodule.
It means that the non-compliant balloon chances of yielding this lesion is very low. It doesn't
Yes.
mean that you have to do rota. You could probably lithotripsy this thing.
Yes, and I was thinking the MLA, what's the MLA?
Yeah, I think you're okay with lithotripsy. I
No,
think.
diameter. Go
Yeah.
get us the diameter of the vessel.
Yeah, the MLA is larger than the diameter of the
Give us
lithotripsy.
the,
Okay, where's the diameter of the tightest area?
A second.
Yeah, here.
I
Minimum
come back to
diameter.
the nodule part. So
Yeah. Nodule is right where the
Around
ectasia
here.
is. You don't need to worry about nodule right there. You just need to worry about 360 calcium, which is, the lumen is enough. I think shockwave probably will go through this.
Is 1.45 the MLD.
Ah, shock wave will.
No, diameter is 1.7.
nodule part MLD is 1.45, and a 360 calcium part MLD is 1.9.
Not
No, that's the
MLD.
diameter.
Diameter, 1.9.
1.9 he says.
Diameter, yeah.
Okay, so we actually have published, and what is a publication that if you have 360-degree arc of calcium at the level of the nodule. Now at the level of the nodule, he is telling us, can you show us the nodule algorithm by the side? That at the level of the nodule, we are probably saying is 2-quadrant calcium here. In that situation, you have to do rotational atherectomy or orbital atherectomy. Then you decide you want to do IVL or no. So let's go. So, but about the burst size, we probably will use like 1.5 or 1.75.
Well, given that he has severe AS,
1.75 bar.
well, let's given
Yeah,
that he
1.75.
has severe AS, maybe you want to go with 1.5, but let's give it a shot. 1.75 she wants.
Yes.
What's the size of the vessel distally? Is a 3O vessel?
Yes, just after the lesion, 2.9 vessel.
2.9.
No, 3O vessel. Give me another
No,
thing.
it's a very big
another, the diameter MLD at that 360 calcium?
1.9.
1.9. Okay.
Yeah.
Your primary lesion is 360 calcium. Your distal nodule is really luminal compromise is not that much. So shock wave may not be unreasonable, but I understand the algorithm that Anu is trying to teach us is when you have that, because of the nodule, I think, atherectomy probably is better in those scenarios.
It's real.
Okay, give us a rota, open 175.
What balloon? 3.5.
Huh? 3.5? 3 to 5, right? That is the 3 to 5, 15 high pressure balloon.
Yeah.
Now there is that side branch, right? I think for the side branch, that's also reasonable. 2.5 millimeter vessel.
I will forget about the side branch.
Yeah. These AS patients, sometimes we give them aminophylline and stuff because, with AS patients, they brady down with rotaplator, so you have to be careful with that. I don't think they have pacemaker, but, sometimes you want to give them aminophylline because sometimes they spiral down very quickly when they brady down. So just be careful with that.
Yeah, let's go simple, provisional, rota to make people happy, stand, and we're done.
And that's a good
So
point.
you're saying, don't forget about the side branch?
Yeah, I
How
wouldn't
many
worry
people
about
are
the
telling
side
me,
branch.
Forget the side branch.
Yeah, send flowers.
Don't flowers? No, I don't like flowers for the branches. I like flowers, but. Okay, if everybody says so. Okay, ready?
Yeah, off carpet.
Yes. Okay, done.
So for the audience, Dr. Kinney, remind us your algorithm to use ROTA instead of the lithotripsy, in this case by the OCT. More than 1.5?
Okay, so, yes, so if you see the algorithm that's playing by the side, right? So what is the key is the MLD at the lesion, that's one, and the calcium plate around the level of the nodule. So the so MLD is giving me is 1.9, right?
Yeah, 1.9. Yeah.
1.9, 1.7. So let's do ROTA from here. So in that situation, you definitely need at least 1.5 bar. No, I'm saying I'm doing rotational atherectomy. If someone tells me, no, I want to do orbital atherectomy, since the arc of calcium is 360 degree, that's okay also. Okay, good. We are the one also, we published that shake it or shave it. That how do you handle nodule? Because there's always a question, how do you take care of the calcium nodule? So in a nodule, you always see some calcium around it. So that is the key. So if you have more than 180 degree calcium around the nodule, you need some kind of atherectomy first, and then plus after imaging, you can decide if the atherectomy has done a great job. That means you have nicely shaved it. Then you go and just do a balloon. If it's not taken care, then you may want to consider IVL, especially if the plate, the calcium around that nodule is more than 180 degrees, like we're talking 3 quadrants, 4 quadrants, you definitely need something more than just a ROTA or IVL for the nodule. But again, the point we are making is that nodule will, respond to either ROTA or OA.
Somehow the,
Slow pecking motion.
yeah. Somehow the bird looks larger than 1.9.
Yeah. Oh, wow. I'll try once more. I think we did majority of the area, right? And then we come out.
You
Enter
increase the
run through
speed? Speed is how much?
Now, 175, I would not want to increase the praise. It's giving 155, right? Yeah. Oh, go up.
What's your speed right now, Dr. Kinney?
155, 155.
Maybe you need a little more, no?
No, but you know what?
maybe 1.5.
What Anu is doing is patience. I mean, this is what you need is patience. Just take your time. There's no reason to rush to go through the lesion. We make mistakes. We just want to push through the lesion. Let it behave. Let it walk. It's going to cross. So you just got to be patient. Any atherectomy, for that matter. We just get impatient. But this is a good illustration of just being patient. It's very thick calcium, so that, this,
And also there's a bend there.
yeah.
So.
Okay,
Undersized?
May not be unreasonable going to 1.5 and coming back to this.
come down. No, okay. What we'll do is run through and then we can just balloon it.
Yeah, that's the other option. You rotate the mouth or the entrance of the
We
lesion.
wrote up probably 80, 90% of the lesion. So we can just,
Yeah, if the rotor had
175
going, the
maybe was a
balloon,
little too
probably won't
aggressive.
heal the lesions.
Yeah.
I might consider just doing lithotripsy now.
okay, you know what? We can repeat with OCT. Give me a run through wire.
If you think it's going to cross, the lithotripsy may not cross.
OCT ready?
Yep.
The only reason of multiple runs of OCT is a dye use. But Kiski will like it because he can now give a clear idea of the lesion modification, right?
Yep.
Kiski? This is going to the side branch. It's telling me, save me. Okay. OCT is ready?
Yeah.
We can do hand injection only.
Sure.
Okay, give me. So I have the rota wire, I did not take it, and let us just do the OCT, see how it is. Ready, Kiski?
Yes.
Ready?
Yeah.
Okay, tell us.
Yeah, can you check the path again, please?
We are not ready yet. We are attaching the syringe. Forward. Okay, you tell us when we
Yeah,
should go.
1 second. Can you
Okay?
check the path?
Okay.
1 second. Can you check the path?
Okay,
Yeah.
puff, puff.
Clearing now.
Yeah, good clearance. 1
Okay,
second.
good.
Okay, enabling. 1 second.
Mm.
Relating. Yeah, cine, inject. Yeah,
Nice.
great image.
Just tell us how far from the side branch the nodule is distally.
What size balloon? 3 to 5? Yeah, 3 to 5.
Relating, angioclastration. Yeah, confirm. Okay, check the image. So this is a distal normal landing zone. This is a nodule part. Yeah, I mean, this is just after the loader within balloon.
Correct.
But see, Dr. Kinney, so like 11
Yeah.
o'clock, there is like a dissection and a fracture, and the surface is like shaved.
That's a
So
nice
yeah.
fracture.
Well, okay, nice fracture. Where can you see the nodule?
So nodule part, like here, still some residual
So
black,
the entrance.
but yeah, but here,
it's
okay,
distal,
so
yeah.
here looks like the shape, the surface of the calcium nodule.
Yeah. Where
is
is
shaped
your
by the
side
roller.
branch?
So we have shaved it. That's it.
Yeah,
Now
you
let
did,
us go
you
with the
did.
balloon.
Yeah.
And just, stent it.
Yeah.
Yeah. And there's some
So that's
dissection in the.
exactly what our publications are. And actually this algorithm, both have been published. The calcific nodule algorithm Kiski actually presented last year in ESC. And if you download the calcific app, which is we have upgraded in a recent version 2, everything is mentioned.
Yeah. And now distal reference lumen 3.3, so we can put at least 3 stent. Lesion length by OCT is 12,
Okay, go.
like 11.2. So 3 or 12 is the recommended stent sizing based on the OCT. And the
Beauty.
proximal part, you can do at least 3-5 post-dilatation.
Look at that.
Yeah.
Beautiful.
Example.
Yeah.
If you modify the plaque and you do these micro, breaks, that's all you need.
So IVUS is telling me you can take a 3.5. My eyes are telling me take 3.5. What is the
This balloon
Yeah,
was
so this
3.0,
balloon-
Anu? The size of the balloon?
3 to 5. 3 to 5. High
3
pressure
to
3 to
5.
5. We went up to 18 atmosphere. Yeah. Now let's see what the side branch is doing.
Good.
Whoa.
Beauty.
Okay. Side branch is listening to Pedro Moreno.
Yeah, if it goes down, it's my fault.
We are long now, right?
Yeah.
Yeah.
3520.
20.
Yeah.
Get us a 3.520.
Maybe longer?
Synergy.
Look at that lesion below, like,
Now
see
then
it?
you have to go 3.0 because distally, then if you want to do something longer than that, will be, I think there's no disease, right, Kiski?
Yeah, just eccentric
so-
disease distally, I wouldn't mess
Yes.
with that. I would just put a shorter stent right past that branch.
But I think the distal vessel was 3.3, wasn't it?
3.3, yeah.
What is
Proximal
that?
is
Maybe too big.
3.5,
20.
yeah.
20.
20, 3.5?
Yeah.
What does the OCT tell you,
So
Kiski?
distal reference EEL is 3.8. lumen 3.2. So 3.5 is yeah, exactly recommended one based on
So
the
the EYE, IVUS, and the OCT are matching. Let's go. So everybody agrees we are not doing anything to the side branch. Actually, side branch looks much better. We're not even going to wire the side branch.
Yeah, the only thing I would say is, you know, when there's calcium and when you have fracture of calcium, sometimes you shut the door, even though there's no disease and the vessel is good. So in this calcium, because of definition criteria, sometimes I put a wire in when you stent it, because if you pull the carina and the fracture of calcium goes in the lumen, it can completely shut it down. So putting a wire is not unreasonable, but I think your big balloon didn't do much, so you think you're okay.
Okay. We are having trouble with every single stent delivery today. Okay. So you see what I did? I
Pull the guide out.
made the guide more coaxial, yeah. Luminal, okay. We took out the rotor wire out. Some die. Okay, good. Go up.
Yep.
Final OCT,
Yep.
down. Okay, and what's the next round now? Lectures?
Yeah, we have lectures.
Okay.
But we want to see, before we move on.
No, we are going to do a final OCT. Get us a OCT. Since we are going to do a cine with the OCT, let's not do another cine right now, save some time.
Yeah, we recouped the delays. We're only 7 minutes behind, so we have time.
I think the first two cases
Yeah.
were the tough cases, which we still did manage, and everything else we are good. Okay, good. Hold the wire. Ready? Ready for the final OCT and the final picture.
Yeah, there will be a little bit of under expansion at the proximal, but I will probably leave with it because post-dilating, let's see.
Yeah, can check the path clearing. Yeah,
Wow,
good.
okay,
Okay, one
now-
second.
Mega vessel.
A second. Okay, enabling, 1 second. Calibrating. Yeah, please cine, inject.
Nice.
Beautiful.
Got image.
Looks beautiful. Any questions regarding the algorithm? Anybody from the audience? I've never had a question from the audience yet.
What's going on with the audience? A lot of people here. Questions? Okay, will be a question. Show us the stent pullback.
Yes, so.
Can you show 3D or no?
Yeah, we can. One
Okay.
second. Yeah.
A little dissection there.
Yeah, well expanded. Yeah, I show you the proximal edge. Yeah, here, well expanded and normal position and no dissection. And I see some calcium fracture behind the stent. The
yeah,
stent is well expanded, like 7, 8.
Looks good.
Yeah, looks great. Well expanded.
Okay, Kiski
Okay.
is super happy. We are
Yeah.
done.
Yeah, everybody's happy here. Dr. Kinney, thank you so
don't mind.
much.
Very good.
We're going to move on. Yeah. Applause for Dr. Kinney.